and we were talking a little bit about some of the disorders of hearing. Okay, it's not something we get involved a lot, but we should be able to screen for it because definitely communication with your patient is critical and can be impacted with hearing loss. We can at least do some basic screening to help determine whether somebody has simply something like conductive hearing loss, which is just some problem with getting the sound vibrations into the cochlea. Okay, so that might be wax in the ear, irritation in the middle ear, some kind of swelling or something like that. Or we can help determine whether the deafness is actually occurring at the level of the cochlea, okay, or the nerve itself. Okay. Remember, once you get into the central nervous system, into the brainstem region or the cerebrum, hearing loss is not that profound. It's usually kind of a difficulty orienting to where the sound is coming from. But with damage to the actual cochlea itself or the hair cells inside of there, that's going to definitely can provide some profound hearing loss. So a couple different ways we can screen hearing. First, the simplest way is oftentimes they'll talk about taking your fingers, lightly rubbing them together, and you'll start with one ear and the next. And it's better if you cover the ear you're not testing to get it out. Have them stick their finger in their ear, cover it, and then you bring kind of rub your fingers together, and you ask them, tell me at the moment you can hear my fingers rubbing together. This takes, though, a quiet room. You got to be in a quiet environment to do this, so it's just hard sometimes in the clinical setting. And you kind of get an idea how far away. You can kind of measure that. You don't have to actually get your tape measure out, but just get an idea. And then do it on the opposite side, and you can do a pretty good job of keeping that a pretty consistent sound. Some people will whisper, 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 and they just keep moving closer and ask the person when they can hear them. But I think a little better just to kind of use your fingers to do that. Used to talk about use your pocket watch and bring your pocket watch. Who carries a pocket watch? I'm sure there's probably an app that you can simulate a pocket watch with your phone and bring your phone. And now, there are apps for testing your hearing. So you could actually take your phone, put some headphones on somebody, and do a quick hearing screen. That's what if you really wanted to do it, they have apps to do that now. So that's just looking at can they hear, okay? But you don't know, is it because they have a conductive loss or a sensory neural loss? Some people have a combination. Some people have wax in their ear, plus they have a bad cochlea, so you can have a combination. So a real quick, simple screen you can do is there's two tests. There's the Weber's test and the René's test, or Weber test and René test. You would use a 512 tuning fork. We do not have a 512. These are either 128 or 256, but you can at least get an idea with this. So you'd want to use the higher frequency tuning fork with that. So Weber's test is the first one. Weber's test simply means what you do is you take your tuning fork, you place it on the crown of the head, and what the person should perceive is that they hear that sound, hear it. It's because the vibration is transmitting down through the skull and actually vibrating the cochlea and the cochlear nerve, creating a sense of sound, okay? That when you do this, they should feel the sound is coming from the center of their head if both ears are working, at least the cochleas and the vestibular nerves are working equally well, okay? And also that they don't have any wax in their ear. So normal is to feel it central, okay? If a person has sensory neural deafness, where you have a problem with the cochlea or the nerve being damaged, they will hear it more to one side, to the normal side, because if the other side is not picking up the vibration that's transmitted through the cochlea and the nerve. Okay, so that would indicate possibly sensory neural loss. However, if they have a conduction loss, if they actually have blockage in an ear of like wax, what that does is that reduces the extraneous noise that's out in the environment. So when you do this to them, they'll actually hear it louder on the side where their ear canal is blocked, or they have the irritation in the middle ear, because they just notice it more because there's less external noise filtering in to compete with that. So it's kind of an interesting phenomena that they get that. So, but in order then to help you screen whether what you found, if you did that Weber's test, René's test will help you identify whether it's is another way to help kind of identify whether it's the sensory neural loss or the conduction loss. So with that one, what you do is you take your tuning fork, you touch it to the mastoid process, and you ask them, do you hear that? And if they say yes, that's good. That means their cochlea is probably, and then as soon as they don't hear it, you bring the tuning fork up to the ear. As soon as they say now, when they no longer hear it being vibrated on their mastoid process, you bring it here, and they should be able to hear it for a little bit longer period of time because your ear is more efficient using its natural ways of using transmission of sound waves through the tympanic membrane and through the stapes and all that stuff is better than just vibrating the bone itself, okay? And so you should hear it about twice as long through air conduction in a normal ear than through bone conduction. So if you hold it here and it lasts for 10 seconds, you should get another 10 seconds out here on top of that. That would mean that they have likely normal sensory neural and conduction. However, if you do this and you put it on there and they say, yeah, I hear that, it's gone. Then when you bring it up here and they don't hear it, that means they have conduction loss. But they have, their cochlea, their nerve is likely okay, but something's blocking the sound waves from getting in to actually stimulate that, okay? So that's Renee and Weber's test to help you kind of clarify what is happening with conduction versus sensory neural loss. So take a moment. A couple of their tables didn't have tuning forks, but share a little bit. 128, when you pull that off, you're not going to hear it much after it may be a little too low frequency vibration to hear very well. So 512 works much better, but there's some 256s out there that'll work a little better. You can either, let me see your 256 here. The 256 is hard to get, that's pretty good. You can also just flick it like this. There's another way to do it, just flick it. There's another way versus hitting it at your hand. Either way, it's fine. So try it out, check yourself. Next, so lesions, we already know about lesions, the cranial nerve number 8. Vertigo, you can definitely have dizziness if you have damage to the vestibular portion of that nerve or the semicircular canal or the utriculosaccule, which you'll learn all kinds about this Friday. And then deafness or combination of those things. There's a fairly common type of tumor that can develop that often affects the vestibulocochlear nerve. It's called an acoustic neuroma. It is typically a schwannoma, so it's Schwann cells that are around the nerve that go haywire and overproduce and create that tumor. It is the most common tumor of what's called the cerebellar pontine angle. So the little angle between where the cerebellum is sticking off the back of the pons. So here you can see this would be quite a large tumor here in this case. So let me see if this thing's going to work here. So you can see I'm outlining this huge tumor right here. And it's impacting, it could be growing off of cranial nerve number 8. Here's cranial nerve number 8, vestibulocochlear nerve. If it gets big enough, you can see it actually can impact cranial nerve number 7 as well. So they can start to get facial weakness too. But it often starts out with more of the acoustic or vestibular dysfunction, and then as it grows, and now you can see the brainstem is actually being pushed off of midline. So it can actually lead to death if you don't have it resected. So the good thing about it is it's benign typically. So you resect it. Oftentimes they don't even have to treat it with any radiation or anything like that. They just do a good job of resecting that tumor. However, occasionally if it's gone on very long and they try to have to pull it off that nerve, you can be left over with some significant nerve damage. But it's a peripheral nerve at that point, so it can repair itself over time. But it wouldn't be uncommon for you if you work in a clinic that does any kind of balance work to see patients after they've had a resection of an acoustic neuroma for you to do vestibular imbalance training with them to make sure they optimize their recovery. So, all right. Glossopharyngeal, we're going to get through these next few pretty quickly. Not as much relevance for us as physical therapists. Glossopharyngeal is a mixed nerve, mostly sensory. So it provides sensory information from the soft palate and pharynx, so the back of your throat basically. Also provides taste from the posterior third of the tongue or so. And it does bring in some visceral afferent information from your carotid sinuses and body. Okay, so it does sense what's going on with as far as blood pressure goes when it samples the baroreceptors in the carotid sinus. Okay, and they're located right at the junction where the internal carotid comes up. That's where if you put a chokehold on somebody, not only if you block blood supply to the brain, obviously, but if you push on, there's actually some martial arts moves where you try to hit the carotid sinus. It's a baroreceptor, and you strike it. It creates the sense that you have rapidly increased blood pressure, and so you causes a response where you have a depression in your blood pressure and heart rate, rapid. And so some people are more sensitive to that than others, and can be fatal in some cases, but most time it's not. You just pass out, and then once you remove the pressure or it has time to recover, you're okay again. It does have a motor component, but it just innervates one little tiny muscle, the stylopharyngeus muscle. Did you guys talk about that in anatomy, the stylopharyngeus muscle? So that's innervated by glossopharyngeal. It has a parasympathetic component. And when we talk about in the cranial nerves, they'll often cause, when we say if something's pure sensory, motor, or combo, they lump parasympathetic function as kind of a motor, because the parasympathetic is an efferent, it's driving visceral function. It's the efferent part of that. So understand that when you do that little mnemonics and so forth, that doesn't separate out whether there's actually an autonomic portion to that nerve. So, but you have to just kind of know that yourself. So the glossopharyngeal does have a parasympathetic efferent component to the parotid salivary gland, is where that goes. So it helps with salivation. It is the afferent limb of the gag reflex. So when somebody sticks something down the back of your throat and touches the back of your throat and you have that gag response, this is where the sensation from the soft palate has to get into your brainstem to initiate. Then we'll talk about the efferent component, which is more vagus nerve that does that. So it's the afferent component of the gag reflex. This one because it has multiple functions, it has multiple nuclei it associates with, and it actually shares nuclei with other cranial nerves. So we have the salivatory nucleus, okay, and that's going to innervate the parotid gland. And we also know that that's also the facial nerve uses the salivatory nucleus to innervate its lacrimal glands and so forth. The solitary nucleus is the sensory portion. That's where the sensory information for taste is going to go, to the solitary nucleus. And that's also where the cranial nerve number 7, taste, goes to that same solitary nucleus that is integrated there. Nucleus, should say nucleus, not nucleus. Nucleus ambiguous. The nucleus ambiguous drives the motor stylopharyngeal. Okay, it's the motor fibers originate there, cell bodies that are going to go to that little stylopharyngeal muscle, or the nucleus ambiguous. It's a motor nucleus. And then lastly, kind of interesting here, is that the sensation of the soft palate and the pharynx, those sensory fibers, they go into the spinal nucleus of cranial nerve number 5. So they actually use the spinal nucleus of cranial nerve number 5, which is pain and temperature for the face. It also integrates, or is where that information for sensation, basic sensation from the soft palate and larynx and pharynx. So here's showing you all the different components and all the nuclei that are used via the cranial nerve number 9. So even though they show all these individually, those are all coming out of one nerve. So there's one nerve that comes out of the brainstem, and then it divides into all those different components. That nerve contains motor, parasympathetic, and sensory fibers in it, but it's just easier to show it this way to see the different components individually of that nerve. There may be a few fibers that branch off of that early on, looks like it has, but mostly coming out from one nerve. If you have a lesion of cranial nerve number 9, glossopharyngeal, if somebody touches the back of your throat, and if you don't feel it, you're not going to have a gag reflex. It could be just on one side. If that damage is to one side of the nerve or the nucleus, the sensory part of that nucleus, you could have loss of the gag reflex because you just don't feel it, okay, back there, so you wouldn't have a response there. You may have difficulty swallowing. You need to have normal sensation of your soft palate and your pharynx to have normal coordinated swallowing. if you don't have good sensation there and you don't have a gag reflex, and also some of the the stylopharyngeus muscle is not a big deal, but it might have difficulty with swallowing. You could aspirate, could go down the wrong way, if you're not feeling that and have that normal gag reflex. And then also decreased salivation. So you could have decreased salivation because of the parasympathetic innervation of the gland there, parotid glands. Vagus, number 10. So vagus is number 10 here. Right, you see it right there. Actually, no, not right there, sorry. It is right there. It looks kind of small there, but it's a kind of a decent size and very important nerve. It is also a mixed nerve, so it has sensory and motor to the larynx, pharynx, and viscera. Okay, so when we talk about motor to the viscera, we're really talking about this parasympathetic efferent outflow to drive visceral function is what we really mean by that. When we talk about true motor to muscles of the larynx and pharynx, but the viscera is really that visceral motor we call a visceral motor response. It's really a parasympathetic drive to the viscera, okay? It has parasympathetic connections or influence over the larynx, pharynx, trachea, lungs, heart, GI tract, pancreas, gallbladder, liver. So the vagus nerve is where a lot of parasympathetic outflow is going to drive a lot of your visceral function, okay, from a parasympathetic standpoint. It is also the efferent component of the gag reflex. So via its motor connections with the larynx and pharynx and the muscles of the larynx and pharynx, the glossopharyngeals, the afferent gets the sensation in there, but then when you actually have the motor response, that's the vagus nerve providing that motor response for the gag reflex. Because it's a mixed nerve, we also have multiple nuclei associated with that. So first one we'll talk about is the dorsal motor nucleus of cranial nerve number 10. They call it a motor nucleus, but it's a visceral motor nucleus. It's a visceral efferent. This is where most of the fibers originate to drive parasympathetic outflow to the viscera. Okay, this is where those preganglionic parasympathetic fibers start. Is in the dorsal motor nucleus of cranial nerve number 10. This one also uses nucleus ambiguus. The nucleus ambiguus is for motor of the larynx and pharynx. Okay, so that's not a parasympathetic motor, it's a true motor to muscles to create a muscular activity in the larynx and pharynx. The larynx and pharynx and those kind of things, and even the tongue and so forth, there's a combination of both reflexive, just like even a lot of our muscles in our limbs, there's some reflexive components and there's voluntary components. I can choose to swallow, and I can voluntarily use some cortical bulbar tracts to drive those larynx and pharynx muscles to do a swallowing response. However, when I'm eating and swallowing, I'm not thinking about it. It's a very reflexive kind of thing happening at the brainstem level without a lot of cortical input or control. Okay, that's the nucleus ambiguus driving that motor larynx and pharynx. And then we have the solitary nucleus again. We've seen this solitary nucleus keep popping up. Solitary nucleus is for afferent, visceral afferent information. So when you're bringing in information about what's going on with your heart, lungs, GI tract, liver, pancreas, that information goes into the solitary tract, is integrated there, and then you can make adjustments to your parasympathetic outflow to those to maintain proper homeostasis.
You have a lot of food in your mouth, and like you would choke on it if you were to swallow. Has that been voluntary for you to swallow?
If you what?
Like if you had a lot of food,
right?
And like you would choke on it if you would swallow. Since it's like involuntary, you said when you're eating, is it turned to voluntary so you don't choke?
I'm not sure what you're trying to get at. So if you have a bunch of food in your mouth, typically you would just then take it more time to allow it to chew it up and to take small swallows of that food versus, but if you take too big of a swallow and it stimulates that gag reflex, then so it's always usually a combination, so especially, if you can, I don't, yeah. Yes, I mean it could become more voluntary if you there's time for you to consciously recognize like this is too much, and so I'm gonna turn off my swallowing response here, allow myself to chew a little longer before I just go ahead and swallow. So it's always this kind of interesting mix of voluntary and involuntary. So solitary nucleus is for visceral afferent, but it's also for taste from the tongue. So you see solitary nucleus being used by glossopharyngeal, facial, vagus. So that's where we get the shared type of thing going on. So if you have a problem with cranial nerve number 10, you will have trouble with difficulty possibly speaking and swallowing, okay? Because the muscles that are helpful for producing sounds and helpful for swallowing are not working properly. It's because you have damage to the actual nerve or the nucleus itself in the vagus nerve. So then you might have loss of gag reflex. This is the efferent part of the gag reflex. So even if you felt, maybe you touched the back of their throat, they can feel it. Hey, can you feel me touching back there? Oh yeah. Well, you should be gagging right now, but you're not. So there's probably maybe something wrong here with your vagus nerve if you're not having a gag response, even though you can feel the sensation back there. They may have poor digestion. Damage to the vagus nerve because of its parasympathetic control of the GI system can lead to poor digestion, constipation, those kind of things. You actually see patients with peripheral neuropathy. When you have neuropathy, it doesn't just affect nerves in your limbs, it affects even autonomic nerves. So you get bad enough neuropathy, people get neuropathy of their vagus nerve. It's a pretty long nerve all the way, and then they start having digestion and GI issues and constipation because they've got damage to they have neuropathy basically of their vagus nerve. You may see asymmetrical elevation of the palate. So when you go ah and your doctor asks you to do that, that's the vagus nerve that helps raise and elevate that palate when you do that. And so if there's damage to, say, the right vagus nerve, and I go ah, and my right side would not elevate, only the left side would elevate. Okay, if the right side was damaged, my left side would elevate because it requires innervation to make those muscles contract. And then what happens is you see the uvula would deviate towards the side that's elevating. It would pull it to the left. So in this case, if I have damage to a right vagus nerve or the motor nucleus of that, okay, the nucleus ambiguous, if I've damaged on that right side in the actual brainstem or the nerve, then, and I say ah, their uvula, their soft palate is going to elevate on the left side, not on the right, and the uvula is going to deviate to the left or away from the side of the lesion if it's in the brainstem or the nerve itself. Okay. Yeah. Yes, they can still feel. Yeah. It is common, though, to have, because they're so close to each other, 9 and 10 are right near each other. If you have a tumor, you have some damage, you may get both. They may hit both of there. They're all of them are coming out of that cerebellar pontine angle area, right at that junction. So, cranial nerve number 11, accessory nerve. This one's kind of a unique nerve. So, spinal accessory nerve. It's this one right here. And you see it actually has all these little rootlets that contribute to it. So you'll notice that it actually has parts that come from the first few, C1 through C4. Some people say C5. There's some cell bodies that contribute to this nerve that are all the way down. They actually form like a little lateral horn in C1 to C4, but we don't have a lateral horn typically there because the lateral horn we typically associate with autonomic sympathetic function in the thoracic spine, right? But there is a little bit of a lateral horn bump there for the success. You really can't notice it, but it's in that lateral, just off the lateral side of the anterior horn there, where there's a few cell bodies that contribute to this spinal accessory nerve, cranial nerve number 11. It's essentially pure motor. There's a little bit of proprioception goes in there. Don't worry about it, but it's pure motor. Goes to the SCM and the upper trap. Okay, so SCM and upper trap. Primarily its cell bodies are in C1 to C4. It has a few cell bodies up in the medulla. That's why it's still a cranial nerve, because it's still few of its cell bodies come from the medulla, but mostly from C1 to C4. It's unique is that it starts in the cervical spine, and it has these fibers that come off. Then it joins to form the nerve, and the nerve actually goes up. It actually wraps kind of around your jugular vein and goes up into the foramen magnum, and then goes up into your skull, then comes back out through the jugular foramen that go back down to your neck muscles. So who knows why it does that. But it is somewhat of a vulnerable nerve because it's kind of long and it traces up there. So if you get some weird, hyper extension and lateral flexion of the neck, you can stretch that spinal accessory nerve. Or when they do a radical neck dissection for like cancer in that area of the neck and face, sometimes they'll damage that spinal accessory nerve, and then you've got some profound, paralysis of this SCM and upper trap and the trapezium. And that's sometimes you're seeing them for therapy because now they have shoulder problems because that they've now got this damaged SCM and upper trap from their radical neck dissection. This one's simple. It's only got one. They call it a nucleus. It's basically a column of cells that are motor cells that extend from C1 to C4 and a little bit up into, poke up a little bit into the lower medulla, okay? They're really not showing actually that this nerve kind of goes up through the foramen magnum and then back down to do that. It kind of goes up into the skull and then back out. Lesions. If you have lesions to that spinal accessory nerve, you're going to have ipsilateral loss of SCM and upper trap if it's a lower motor neuron problem. Upper motor neuron paresis, you tend to have bilateral. If you want to voluntarily contract those muscles, there tends to be some bilateral connections. These are more proximal medial activation system muscles that are innervated. So if you have a problem with a stroke, you tend not to see profound loss of upper trap SCM function one side versus the other. So if I have a left-sided stroke, it's not like, my neck is going to be really weak on the right side. My limbs might be weak, but because there tends to be more bilateral connections, especially with proximal muscles, and more of your proximal muscles are mediated by these medial activating system tracts, vestibulo, reticulo, tectospinal tracts, that you tend to see less profound. It's only when you actually damage the peripheral nerve or the nucleus that you see this profound atrophy and loss of function just on one side. So upper motor neuron problems, you don't tend to see this profound side-to-side difference. Maybe a little weakness on one side, opposite of the lesion for an upper motor neuron, but it's only when you have this, lower motor neuron lesions that you see this more obvious loss. Last one, hypoglossal nerve. So this is to the tongue. And so this is the right here. So this is the one where you're coming. This is kind of the ventromedian fissure here in the medulla. This is like the ventro-intermediate fissure. Then there's a lateral fissure. So this is coming out of the intermediate fissure right here. Hypoglossal. It's motor, pure motor, tongue muscles. Like a lot of things, it has both voluntary and reflex circuits. So you can choose to stick your tongue out when you want, curl it up, do whatever you want with that. But most of it is reflexive in nature for chewing, swallowing, those kind of things. If you have lesions to it, if it's in the brainstem or the nerve, you'll have ipsilateral weakness, kind of like we were talking about with the vagus nerve. If you have damage to the nucleus in the brainstem or the nerve, your tongue's going to be weak on that same side, okay? If it's in the cortex, it's going to be contralateral weakness, especially with voluntary control or movement of the tongue. So nerve or nucleus in the brainstem. My tongue, let's say it's on the right side, my lesion's on the right side. I've got a little tumor, I've got a little damage to that hypoglossal nerve. I tell the patient to stick their tongue out. And it's going to go If it's weak on this side, the tongue is going to be weak. So in order for you to stick your tongue out symmetrically, the muscles push it out, and they have to be equally doing that on both sides. So if my nerves, if my nerve system and my hypoglossal nerves on both sides are working effectively, my tongue can go straight out. But if I'm weak on the right side and the damage is to the hypoglossal nerve on the right, the muscles on the right are not going to push out as much. So the left is going to dominate, and the left is going to push too much, and the right's not going to counteract that. So the tongue is going to appear to curve towards the right, towards the side of the lesion, if the lesion is in the nerve or the nucleus. So ipsilateral, the tongue will deviate towards the side of the lesion. So you have ipsilateral deviation of the tongue. The tongue will deviate towards the same side as the lesion. However, if the lesion is up in the cortex, because this is a voluntary thing I'm doing, I'm being asked to stick my tongue out, so that is actually, you send a signal from your cortex down to the nucleus of the hypoglossal nerve, or into a nucleus, to tell it to do that. If the damage is up in the cortex, if it's on my left side, cortical bulbar tract goes down, crosses over to the other side, and tells the hypoglossal nucleus, send a signal out the nerve to make the muscle move. So if the damage is on the left side of my brain, the tongue will also, the weakness will be on the right side. The tongue will deviate, but it's going to deviate to the opposite side of the lesion, so it's contralateral to the lesion in this case. Does that make sense? If it's a central nervous system, cortical bulbar, the cortical bulbar tracts. The cortical bulbar tracts are the tracts that run from your cortex down to cranial nerve nuclei that you have some voluntary control over, okay? And so if the cortical bulbar tracts are damaged, those all cross. So anytime you have a cortical lesion, a cortical bulbar tract lesion, typically the loss of function is going to be opposite side of the cortex lesion. If the lesion's actually in the brainstem, actually affecting the cranial nerve nucleus or the nerve, then your loss of function, whatever that may be, is going to be ipsilateral on the same side as the lesion. Okay? So with the tongue example again, if I have now, let's switch, let's go right-sided cortex lesion, and I ask you to voluntarily stick your tongue out. So if I have a cortex lesion up here that's in that facial tongue region of the homunculus, you know what I'm talking about, that's very common with a middle cerebral artery stroke, which is a very common type of stroke, is that lower face and tongue, voluntary tongue control, it will be damaged, that area. So I ask you to stick your tongue out. That cortical bulbar tract crosses over and goes to the hypoglossal nucleus on the left side. So my left side of my tongue is not going to work as well, okay? And so when I tell you to stick your tongue out, your tongue's going to deviate to the left because your left muscles aren't pushing hard enough to keep it straight. So your right muscles are going to push it to the left. So your tongue is going to deviate contralateral to the lesion. So the tongue goes to the left, lesion is on the right. However, if I have a tumor down on my brainstem, and there's a nice MRI that shows this tumor in my brainstem, or I had a stroke in my brainstem that affected the hypoglossal nucleus in the actual brainstem, and I tell you to do that, it's going to deviate to that same left side if the lesion's on the left, so it's ipsilateral to the lesion because the lesion's in the brainstem, okay? This is just looking at the back of a brainstem, and you're kind of peering into the brainstem and seeing all of the cranial nerve nuclei at one time. On this side, this is showing you all the motor or efferent nuclei. Either things that go and drive motor function, pure motor, or go drive parasympathetic efferent. Okay, so you're seeing all those on that side. This is showing you primarily here the sensory nuclei on this side is what they're dividing that up. This is from the Crossman book. If you look at this a little bit, it's not a perfect thing, but motor nuclei tend to be more medial, okay? There's a few exceptions, okay? But the motor nuclei tend to be a little more lined up midline and more medial, where the sensory nuclei and parts of this solitary nucleus here are more lateral in nature, okay? So this big red thing, that's the trigeminal nucleus that includes the mesencephalic portion, the main, the spinal, the spinal nucleus. Then the green area here, this is your vestibular and cochlear nuclei all together, okay, that whole apparatus. Then this blue part is a solitary nucleus here. And so when we start getting through cross sections through the brainstem, especially right here in the medulla, when we start looking at these cross sections, you can start, if you're really trying to struggle to guess on a test, where if you see a cross section and if you see something circled more medial and versus something more lateral, and your choices, your multiple choice questions, if it's more medial and you see a motor nucleus and all the rest are sensory, you're probably going to lean towards that motor nucleus. But we're going to go through all the cross sections here so you get to see what I'm talking about when we get to the brainstem here. Descending control of motor cranial nerves. So this is what I've been talking about, the cortical bulbar tracts, okay? So we have tracts that go from our cortex. This is the descending kind of voluntary control over cranial nerves that have some motor function. Larynx, pharynx, tongue, face, those kind of things. That's what we've been talking about. So most cortical bulbar tracts fibers cross, so lesions are typically contralateral to the deficits if it's a cortex problem. There's a little bit of an exception. Remember, the upper face tends to have bilateral connections, so even if you have damage to one side of your cortex and you tell somebody to raise their eyebrows, it looks pretty symmetric because they're still getting innervation to both sides of their face from the left side of their cortex because there's a little more cross bilateral connection. But the lower part of their face will likely be much weaker contralateral to the lesion. Okay? If the lesion is at the level of the nuclei in the brainstem or the motor neuron, the lower motor neuron, that cause they'll have ipsilateral weakness, same side as the lesion. Okay. There's also some limbic pathways that come from our limbic system that go to the motor nerves of the cranial nerve nuclei and also to the vagus nerve for parasympathetic drive. But you know, when your face responds with grief or surprise or happiness, those are limbic structures that drive the motor function for basic facial expressions that are more automatic in nature, that are associated with different emotions. Okay, those are some limbic. They're still considered kind of cortical bulbar. They run along with the cortical bulbar tracts, but they're coming from the limbic system, which is deep. And the cortex is literally the cortex, the surface of the, but they tend to integrate with those cortical bulbar tracts, but they're coming from the limbic structures, the cingulate gyrus and those kind of things drive some of that. Okay, doing all right? Let's, any questions on cranial nerves? Yeah. Hypoglossal would cause a lot of speech impairment, yes. They would have difficulty with speech. Remember we've talked about, and when we get to the cerebrum, we'll talk about differences in language impairment. So if you have damage to the cranial nerve for vagus, hypoglossal, or glossopharyngeal, those three big ones are the ones that control your tongue, your throat, larynx, pharynx, soft palate, okay? Damage to those nerves, or those nuclei, will typically cause a speech deficit called dysarthria, where they have trouble speaking because the muscles are weak and they can't form the words very well because they can't contract the muscles. But they know what they want to say. The problem, they're not having a trouble formulating what they want to say. That's a cerebral thing where you actually language. It's on the left side of your brain, kind of in the parietal association cortices area, that you formulate, I want to say this, that you send the signals down the cortical bulbar tracts to those muscles. But if the nuclei or the nerve down there in the brainstem is damaged, you can't express yourself. It'll sound funky because it's dysarthric, because the muscles can't coordinate or they're too weak to form the words properly, but you know what you want to say. Versus if you have damage to just the cortex in the area where you come up with what you want to say, you may have perfectly good larynx, pharynx, you can swallow normally, but when you try to say something, you can't get it out, not because the muscles are weak, but because you can't formulate what you want to say in that area of your brain that helps you know this is the motor planning area for speech. So that would be an aphasia. That would be expressive aphasia. Sometimes you'll have both. If a person has a big stroke, it can cause damage to the part that helps you formulate the words, but can also cause damage to the cortical bulbar tracts that help to keep your muscles working properly, so you can be both aphasic and dysarthric. So they can't figure out what to say, but they still have dysarthria as well. So this combination language deficit that they might have. So, got it? All right, let's